everybody. Good evening, and thank you for taking time to join our Foxy Gyan Pravah podcast. We are very delighted. Now we are almost at the close of this year. We have gone through this whole everyday marathon under the guidance of our president, Dr. Tandulwadkar. And I think it was a new idea, and we connected with so many people, not just gynecology related people, but leading figures in various avenues, which all affect, and we are a part of the larger life, isn't it? So we now will actually, I will invite Dr. Tandulwadkar to welcome our guest of today, a very respected, revered, anybody who has any learning experience as a student in North India will be respecting her so genuinely and deeply, like myself. So I would request Dr. Tandulwadkar to welcome Dr. Abha Majumdar.
Thank you. Thank you, Anu. Abha, welcome. Welcome on a Foxy platform. I think Foxy platform like this, we are meeting for the first time. We are so much together with the ISAR IFS conferences. But Gyan Pravah podcast series is designed only for the committee chairperson. We have 30 committee chairperson, 30 days, 30 people. 29 Jan, we started it, and Anu was the opening batsman because 29th is the day given to her. And I can't believe that 11 months have passed, and we are doing this podcast. Today is 335. So every day, 8 p.m., I join just to show the respect to faculty, to welcome them on our platform because many times we don't have gynecologist. I think only 10% we had a gynae. Otherwise, we have from all other fields of political, spiritual, social, and so many achievers we have interviewed. So this is a very prestigious platform where the renowned faculty who have done a lot in their life is always welcome, and the dialogues are beautiful to listen. So thank you, Abha. After long, I got a chance to
for
catch up
having
with
me.
you. And me and Abha had a very different and deep level relationship as a DNB FM students inspection and everything. Abha keeps on or used to keep on visiting Ruby Hall, and we used to share one day together. Lovely meeting you, Abha, again.
Same
Thank
here,
you so
same
much.
here, Sunita, and so good to see you in this special position. This is the first time I'm probably interacting with you as the Foxy
After
president.
Foxy.
Yeah, yeah.
I know. I'm so glad we met. And Anu, thank you so
Yes.
much. Continue. Our protocol is Abha. I joined the viewers link, and only you both will be in the full podcast. So I'll see you from other end. Bye,
Okay.
Anu.
Thank
See
you.
you.
Thank you, madam. So I will now formally introduce Dr. Abha Majumdar. She's a renowned fertility specialist and pioneer in reproductive medicine, heading the IVF department at Sir Gangaram Hospital, Delhi. I'm sure many of you would know this hospital, the values and the respect that it has carried over many decades. With over 40 years of her experience, she delivered India's first IVF baby in North India in 1991 and has ever since transformed countless lives through advanced treatments like IVF, IUI, and egg freezing. A recipient of multiple awards, including Best IVF Clinician of India in 2022. Dr. Majumdar is known for her very compassionate, patient centric approach and contributions to fertility education. And this is something which I try to keep it very brief. Otherwise, if I start counting your awards, the biggest award I think you have is that, like I mentioned, anybody who has connection in the learning as a avenue, as a student of this subject, anywhere connected in North India would deeply and so genuinely respect you, and that is the biggest award that somebody can gather.
Really true. Thank you, Anu, for this kind introduction. Now you can shoot your questions.
Yes. Do you want to say anything to our viewers before I start the questions?
I felt very happy when I was asked that, I had to answer some questions in a podcast format, and I think I would be able to speak some of my heart here. Let me see what are the
Okay.
questions and what can I say in while answering them.
It's your play field, so please say anything that you
Okay.
wish to share. And yes, I will start with basically that you were part of the team who delivered the North India's first IVF baby in 1991. For any doctor, it's a very important part as a career. Looking back, what were the biggest technical and societal challenges in in making IVF a reality in India at that time?
1991 was early for India because the first baby of India, the first documented baby was born in 86 with the efforts of Dr. Indira Hinduja and Dr. Anant Kumar. And North India was still struggling. You know, the literacy is low, the population is high. So, but still, Delhi was trying to cope with that. And I would truly give the whole credit to Dr. Bhandari, who was the head of the gynae department then. And she was the one who in 89 asked me, will you give up gynae and ops to develop infertility and IVF? And I agreed. My boss, Dr. Kocher, was not too happy, but yes, she had no option because I was her junior and I was a working gadget for her. So we developed. Well, the biggest difficulty was that we did not have availability of culture media. So
Mm.
we got an embryologist who was like a makeshift embryologist. She was a genetist who retired from AIMS. She would make her own media. She would measure all the salts and make a media. Can you imagine? We used to triple distill water in our own center. I still remember that huge triple distiller which we had. So it was quite difficult to start on the technical side. On the other side, there were no training centers. There was no one who was doing IVF. Mumbai had a few people like Dr. Sadhna Desai, Dr. Indira Hinduja. They were the two names over there. Calcutta, Dr. Subhash Mukhopadhyay was long gone away. So there wasn't anyone whose name would crop up. Dr. Gunashila in the south was another person. So, you know who my teacher was? Often people ask, who taught you IVF? And I said, fertility, sterility, and human reproduction.
Oh, wow.
That is what I used to read chapter by chapter, all protocols. How do we assess? There was no AMH, there was no antral follicle count. It was just FSH, LH, E2. And we would look at small things. E2 rises faster, it's a good responder. E2 goes slowly up, it's a poor responder. That was one glitch we had. And another one was procuring the agonist. Antagonist was not anywhere then in 1990s. It came in the later part of 90s, I think. So we used to get it from Sukh Sagar chemist in Bombay. Dr. Sadhna Desai gave us the address and we used to ask him to send the drug to us. So far as the technical part. Societal part was another big glitch. People did not want to accept, even if they had IVF. They were so desperate that they came for it. They would not accept in front of anyone. In fact, they would go away for deliveries to other places. That if we deliver with you, maybe we'll be
Yeah.
caught. They used to think gametes, God knows whose gametes they are using, whether it is my husband's sperm, my eggs, or someone else's. So there were a lot of misconceptions on the society's part. And plus, they did not want to reveal to anyone that they are undergoing IVF, and we had very little to offer. We had no success rates. There were no rates. There were just success stories that, oh,
Yes.
today one patient got pregnant, maybe after a month, another one got pregnant. And the first year, we got 5 pregnancies only.
Oh, wow.
And then second year, we went up to 11. So it did grow with time, but yes, it was great effort, great, great effort.
It must have been because I'm actually shocked. I don't know anybody who is self-taught by reading to journals. I mean, kudos to those journals
Yeah.
who were so helpful and far-reached that from some other place of publishing, they could teach somebody sitting in Delhi like you with no teacher.
I had
So this
I had
is
hard copies of all these with me all the time. And every article which used to come on stimulation, just read it. So
wow.
it's
So
how
you're very self-taught actually then. So that is a very good path, but difficult one. Yeah.
I was self-taught even when I did my MBBS and my MS because I never had any tutors. We couldn't afford to have tutors, so I
Yeah.
just learned on my own. So I was used to self-teaching myself.
I think that's the best way to stimulate your brain and get your answers within the books. And that's a very standard way because it's only very good level of publications that you followed, and the foundation is so solid. So moving on, having practiced 40 years, which innovation do you truly see as the breakthrough or biggest game changer? It could be like something like ICSI or vitrification or PGT. And why do you think that particular breakthrough is so game changing?
I think, Anu, every breakthrough was a game changer. It was such a huge thing to happen. ICSI, it didn't happen by choice. It just happened accidentally, and it changed the whole world for male infertility. Every man who had even one sperm could father his own child. So ICSI was a huge revelation. Then you said vitrification. I think that was another leap. Vitrification led to so much of frozen embryo transfers. The complication rate has gone down. The OHSS rate has almost disappeared. What else would I say? We have one embryo transfer. I mean, there's leaps, and we used to do cleavage stage embryo transfers,
Mm.
maybe day two only.
Yeah.
Day three, it was difficult for us to think that our embryos would grow till day three in the culture media which we made. And we got pregnancies then.
Mm.
So now we do only blastocyst culture. Every patient's oocytes, sort of embryos which are fertilized, go right till blastocyst, even if day three is not too bright with them. And we do find surprisingly very good blastocyst come up on day 5 and 6 for these patients. So 100% blastocyst culture is done at our center now.
Okay, so you only do the blastocyst.
No, we do have day threes also, but we
Mm.
tend to take everyone to
Yeah,
blastocyst.
yeah,
Even if they're not good embryos on day three, we still go on
yeah.
culturing them, and surprisingly, some turn out to be very good. So
Okay.
vitrification became a very good method, and definitely PGT opened a whole new Pandora's box, not only for aging women who enter IVF so commonly,
Yeah.
but also for genetic diseases, for translocations, which had no answer before PGT could be done. They
Yeah.
just went on getting pregnant and aborting children if they found they were diseased, because I think CVS had become available at some point of time in the 1990s.
Yeah. So now I want to talk about something which really made me wait for the opportunity to bring you here, which is your master classes. So you have conducted extensive free master classes teaching the ovarian stimulation and talking about tricky cases like endometriosis. So what is the single most important clinical principle that you talk about when balancing egg quality with the disease suppression, for example, endometriosis? I want to go technical a little bit.
Yeah, I know. I'll tell you earlier, I did think that egg quality gets worse with endometriosis being there, but now there is enough evidence to say that antioxidants don't help, even if we think that this is oxidative stress, which is happening because in the presence of that little inflammation which goes on in women with endometriosis, live births are same. If you see Shesh Sunkara and Mohan Kamat's 2022 meta-analysis, no effect on live birth, no effect on embryo formation. In fact, women with endometriosis, I mean, earlier it was just the reverse. We said if we took eggs from women with endometriosis and transferred them into someone else, they fared very poorly. But now the whole game has changed. So I don't think that endometriosis per se has any detrimental effect on the egg quality or embryo formation. But yes, I do feel that it affects the number of eggs which we can obtain, the ovarian reserve. The disease per se can affect that. The surgery for that can affect it. So both ways we go down, whether we do surgery or we let the disease grow. Both ways the numbers go down more. Earlier, maybe our culture systems were not so robust, and so we really thought quality was impaired in these women. I don't think personally, now I don't give a damn to if you have tuberculosis, small cyst here, there, big cyst also. My main aim is take out eggs and convert
Yeah.
them to good embryos. That's
Yeah.
it.
So, yeah, these are the things that, when somebody like you confirm, then people gain the confidence. And I don't want to, normally we don't go technical in these podcasts, but I don't want to lose the opportunity of having you and not asking technical questions. So you are widely respected for managing complex and high risk IVF cases. And how has your approach been to the poor responders? Endometriosis, of course, one of the ones that you've already mentioned. So so how has that evolved with the personalized stimulation protocols and modern lab advances?
Yeah, I know this is like it was teaching for me also. We didn't know what to do with these poor responders. We use agonist or antagonist. Sometimes the cohort was not good. Sometimes, we just got very few eggs. Now I have learnt my lesson. It has to be collection of embryos, especially of women over 37. So I go for duostim. In fact, mine was the first paper published from India on
Okay.
duostimulation. So it is in JHRS, which is an open access journal, and anyone can read it. So I think a lot of people have now started doing Duostim, but I have so much now confidence on Duostim.
Is
And
it?
then my colleague started Bystim, and I also take up Bystim when the patient takes a little time to make up their mind. But I have felt nothing has worked better for poor responders than
Yeah.
stimulating again and again till we get a breakthrough of mitochondrial replenishment or something which we can do to these few eggs which we get, and they can make A-class embryos for those little
Yeah.
eggs. But if you get three eggs, what do you expect? You would get one, maybe, or maybe at the most two if you're very lucky, otherwise, none. So you have to counsel them right from the beginning, tell them their chances because of their ovarian reserve, because of the underlying disease, and because of their age, that you would need more embryos, and therefore to make more you will need more oocytes, and if we get only 3 or 4 in one cycle, you will have to go through 3 or 4 stimulations to get that many embryos. And that I do. And I don't know, people say it's very difficult to counsel them. My patients agree so easily. I don't know, maybe it's it's
That's easy for you. That's definitely when they know who they are being
Yeah, I think
advised
maybe
by.
that could be
Yeah.
one reason, or because of the conviction I explained to them. And I'm so confident that, go through another one. And if in 2 or 3 stimulations we don't make embryos, you are not going further. 2 stimulations, no embryos, I want to cut them. And still I get requests, ma'am, एक और try कर लीजिए, duostim, हो जाएगा, सबका हो रहा है, मेरा क्यों नहीं होगा, that type. But I like to stop if I don't make embryos within 2 stimulations generally.
Within two. So that was I was going to ask you that when do you
Two
start
or
counseling the other
two,
side?
two. Very rarely 3 if the patient insists. But in 2, if we get 2 eggs, no embryos, or 3 eggs and no embryos, or 4 eggs and no embryos, then I tell them there's something really wrong if we're not making embryos with your eggs and your husband's sperm. I don't offer them donor very easily.
Yes, nobody wants to hear these words very easily.
Yeah,
Yeah.
but Indian women are so tuned. I mean, they have very good reserves, and they go through IVF with donor eggs, and they come to me and say, "वो सब जगह donor use हुआ है, आप भी donor करेंगी?" And then I look at the reserve, I look at the age, and say, "नहीं नहीं करेंगे हम आपका, if you agree with whatever lower chances of pregnancy you may have with your own reserve." So that's it.
Yeah. I
So
think
a
that's
cycle approach is what I really like to do.
yeah. I
Before
think
I
the practice
एक
is
ट्रांसफर कर दिया और वो नेगेटिव आ गया, the patient will run away for 6 months. You lose her age, you lose an opportunity to stimulate. But if she is mentally clear that
yeah.
you're going to stimulate her time again, you
Yes.
will agree very beautifully.
Yeah. You start by saying that it's a series that you should expect. Yeah. So, as someone skilled with in both the fertility enhancing surgery and ART, how do you decide when a patient would benefit more from the surgery versus proceeding directly with IVF?
This is in which case? All cases? Any case?
Say an endometrioma of 4
Ah,
centimeter.
okay, so you are the endometriosis chairperson, and so I thought that it wouldn't be any surgery like a submucous myoma, polyp larger than 10 millimeters, maybe removed surgically. But yes, endometrioma, Anu, I'm very, very conservative about surgery now. because I've seen how dramatically the ovarian reserve goes down. I feel so bad when patients come and say, you did my laparoscopy and now my ovarian reserve has come down to 1. And we know that in the best of hands, 40% reduction is very, very likely, because endometriotic cyst is very densely adherent to the sort of ovarian tissue all around. And when we peel it off, some amount of ovarian tissue goes away with its follicles and with the little cautery we do. So if I can do without surgery, I would go ahead. Otherwise, what I really do is, if I think the follicles are approachable, they are on the vaginal side of the cyst, then I would really want to, because stimulating doesn't increase the cyst, and I'm not bothered about stimulation and increase in cyst size. I would want to aspirate all those follicles, make sure that I've made 2, 3 embryos for that young girl, and then I would say that, you have a 5 centimeter cyst or a 6 centimeter cyst, or a cyst whose volume is more than 60, 70 ml. It's better to have it removed, because it'll, and that also, if she has pain and symptoms, if she has no pain, I would quietly do a transfer also in her, maybe give her a GnRH agonist for a little reduction in size, just reduce the inflammatory markers and do embryo transfer. And if she gets pregnant, that's the best cure for her cyst further on.
Yeah, of course. Yeah, because
I do surgeries. If there is pain, I definitely do. If there is large cyst and the diagnosis is in doubt, I've 100%. I've got an endometrioid cancer once, in endometriotic so-called. It just grew in size. So you have instances, but she's already had a surgery, low reserve, bilaterality, please don't touch her with a surgical hand, however good you may be.
yeah, I
If
also
she
want to
already
ask
had a
you,
surgery, yeah.
yeah, do you use Dynogest for the medical management of
Yeah,
symptoms first?
I do use, but that is Dynogest I like to use when fertility is not their concern.
Yeah,
They
yeah,
come
of course.
much before. I
Intermediate.
love to put them on Dynogest. Earlier, I
Okay.
used to use a lot of OC pills, but I've reduced because of that little estrogen which is there in it. And I give Dynogest, and if it suits them, it's excellent. Maybe sometimes Marina also.
Yeah,
And if
yeah,
they don't tolerate these two for whatever reasons, water retention or other things, then it's continuous OC pills.
yeah. So, you run one of the most sought after F&B training programs, and what is the one non-negotiable skill or value that you think every young reproductive medicine specialist should develop before they start independent practice?
Yes, this is a very, very important question. Skill they all learn. They have enough to see. They have plenty of hands-on, whether it is oocyte aspiration, embryo transfers, TESI, TESA. They have really learned and skilled themselves. They get lots to do. But the one thing I want them to carry from my clinic, and they carry, I'm so happy that most of my students have carried, is ethical practice. Ethics to be included in everything, transparency. Please give a discharge slip to every IVF patient. They deserve it. The accountability of every oocyte you've taken out should be written very clearly. There's fertilization failure. Don't hide behind. Tell them, come forward and say that nothing fertilized or nothing cleaved beyond day 2 or nothing cleaved beyond. So transparency, ethical practice, and of course, compassion goes with that. Unless you look into the eye of the patient, your soul doesn't connect with the patient. Your mind connects with her problems, but the soul connects when you look into her eyes, and then the compassion comes up and you see the pain in their eyes. So this is what I want all my students to go, that, and they tell me this, I get calls from them. Ma'am, you taught us PCOS doesn't need IVF. Here they are doing IVF for every PCOS. But you taught us that PCOS only needs ovulation induction and good timed intercourse, or maybe at the most IUI. And I said, see, if you're working somewhere, always bring your point, but you will have to listen to the person under whom you're working. So it's sad, but then there are lots of them who, you must see the messages I get from my students. Like, they do such good ethical practice and they're so proud of it.
Yeah.
That, I lost a patient, but I told her that you don't need IVF. I lost a patient, but I told her the truth that IVF won't help you.
That is very, very important, especially when a country like India, where the practice itself is very non-uniform.
Yes.
Patients are not aware of what is happening with them. So I think we need more people who actually inculcate this
I have
practice.
now so many who've gone out, and I'm so proud. 90% are doing absolute ethical practice. Yeah, 10% they get into alternative medicine and, adjuvants and this and that, whatever you can add on, make cocktails of everything, make cocktails. I consider that one drug on the prescription is best followed. If you have 10, they might follow the less important ones and forget the more important ones.
Yeah.
I've also taught my students that I want to see your prescriptions with just the fewest number of drugs which can cure this patient and sort of give her healing, and not a tubular vision when they come for IVF. Please broaden out. Breast cancer and cervical cancer is the biggest killer in India for women. And these two come under the domain of a gynecological practice. So please educate them regarding a liquid-based cytology, HPV smear, vaccination. Well, you cannot give when they come for infertility, but yes, at least a pap smear, jisko, which is in common language you call that, and self breast examination for every girl. Whenever you think something looks different, please ask for an ultrasound. After 40, like USA has colonoscopy for all men, after 50, India should have mammography for all women. Because breast cancer is really the biggest killer in our country. It is the highest in numbers. So I tell them, don't have a tubular vision. Just look this way, that way also towards her health. And don't forget that taking a pap smear, doing a per speculum examination, asking her to do her own breast examination. You wouldn't find anything in a 2-minute examination, but she would definitely be able to find. This is
Yeah.
what I teach them when they leave me.
This is so important. I mean, although we know this, but we do what our teachers do and what is habitual in our, observation when we are learning. So I'm actually unable to re-emphasize it any further. You've already done that, and we really want to promote this. Even I was more sensitized when I got involved in Foxy programs, and your mind works like what you talk about or what is your habit rather than what you know.
Yeah.
So, so I totally agree with this point. So, you have written thoughtfully about knowing when to stop fertility treatment. You're known for this concept that you really say that there is a sweet spot that you have to hit and you have to talk about closure. How do you approach this emotionally difficult conversation? Do you want to share about those early, younger people who are just starting this journey? Because it is difficult to talk about closure sometimes for them and for repeated IVF failures, especially.
I remember once upon a time, maybe in the early 2000, Eve's Weekly had an article from Mumbai from a Parsi lady who wrote with a lot of pride, my 19th attempt at IVF, I have eventually had a child. So, I mean, like people boast about a 78-year-old woman having a child or a 60-year-old woman having a child. Where are we going?
I
I mean,
know.
we want to play God, and what are we doing to that little child, unborn child, who's going to come into this world with parents who look more like his grandparents? And when he goes to school in this rapidly advancing world, how would his complexes develop and how would he feel? So I feel that, we don't have to play God. We have to, at one point of time, only when we accept that we cannot do anything further for this, the patient understands. When you start showing desperation yourself, when they say that sabko chhod ke I've come to you, and now you are saying that can't do better than this. They are recurrent implantation failures. You cannot do anything for them. I don't believe in treating them immunologically at the moment unless I have a proper diagnostic clue. And we know all these immunological factors are inconsistent. In one cycle, you'll see a high, you try natural killer cell, in the other one, it
Yes.
disappears. So this has no relevance. So I feel that, at one point, and the best person uh, to do counseling is you yourself. No counselor will be able to tell them about closure. So you have to call them into your own facility, not into your OPD, which is my OPD is like so rushed
Yeah.
that I cannot think of counseling anyone regarding a negative counseling. It
Hmm.
has to be done in my office in the IVF center, where I call all failures also to counsel there, and all jinka closure chahiye hai.
Yeah.
It is the
Super
clinician
important.
who can counsel. No one else can counsel. We have nurses, we have a very good technician. I mean, people dote on them. That, oh, I
Hmm.
want that nurse, I want, but still the final
Hmm.
counseling has to be done by the clinician
Hmm.
herself or himself.
Yeah. This is so important. I can think of very few names who from whose mouth I've heard of this. Very few in when I talk about India or UK both among my own teachers also.
Mhm.
So there has to be a stop somewhere. We can't say that. Yeah, I actually saw somebody very senior boasting about somebody doing 28 cycles, and I was like, you have to choose your teachers wisely is what came to my mind on that day. So with the implementation of the ART and surrogacy acts in India, how do you see fertility practice changes for the average OBGYN over the next few years?
I think those who are conscientious do love these ART guidelines. And as far as donor goes, there is hardly any inhibition for donors.
Hmm.
Um, I mean, we can take donors because they've now agreed to non-anonymity. So it is confidential, but you don't need to be anonymous. So I'm very happy. Second thing is that they've made formats for consent forms, though one or two lines here and there are lacking, which we wrote to them, and maybe in the next bulletin they will incorporate that. But there are good consent forms, and I really wish that everyone gives them a good discharge summary. That is what they write in the ART Act, and I want it to be implemented. So, for couples with their own gamete, ART Act is very good for us clinicians as well as for the patients. But those who need third party, whether it is donor eggs or surrogate, surrogacy has become difficult, really difficult. But then I think it was going very haywire. It was going very haywire, and that is what gave a bad name to IVF in our country.
Hmm.
IVF was like, I know what my position was when I was doing IVF, and people used to really come with a lot of respect. The moment surrogacy came in and Bollywood took over surrogacy, that is when, the politicians woke up to this thing, and then they paralleled surrogacy and IVF. Surrogacy is a minuscule of IVF. Like if I do 100 cases of IVF, maybe one case of surrogacy comes in. Genuine surrogacy
Yeah,
without
yeah.
or RKS syndrome or something where, hardly few people need it. But, putting a ban like this have taken away that facility from people who really needed it.
Hmm.
That is one second thing. But IUI was being done rampantly. I'll tell you here, there, sperms prepared here, transported to
Oh.
Delhi. That has come to a stop. That you cannot do that. You have to do it. And plus, there is a registration of level one clinic. So that has become a good thing, that at least you register and you do IUI and you have all facilities there. Earlier, it was being done by everyone and
Hmm.
anyone. It was just inserting. I mean, I had people who came and told me, gynecologist, you taught us. We do insemination with raw semen. We don't prepare it. They put raw semen into the uterus. Imagine what would have happened to that lady. And I said, I mean, keep your brains open when you hear something. It is a semen preparation is very important. So I think ART law was required for this country. It does have hiccups like any new law has in any country. And with time, I'm sure that these hiccups will clear out and we will have clearer guidelines for every step. I'm
I've
happy.
never heard of this actually. I'm shocked to hear this, what you just told me somebody did. And now I feel that yes, this law is actually much later than when it was
Yeah,
required.
yeah. So I'm very happy about the law. I feel
Mm.
at least some restrictions are somewhere. No XYZ gynecologist can just put in do IUI.
Yeah, yeah. So, as a former chairperson of fertility committee of the Foxy, what more can the federation do? I mean, I really wish you had given more time to our federation. But what do you think? we can do more to standardize IVF reporting, the success metrics,
Yeah,
and the ethical
I
practice?
have two thoughts on this. One is that there is a Foxy certification given for training under Foxy for advanced infertility. The centers should be chosen very carefully,
Hmm.
just to get more candidates and a little more sort of financial resources which come from every student paying a fee. I think they have to be chosen very carefully. They should be given a whole plan of their whatever they need to learn in the next 15 days, or every center should be sending them plans, which we have in place.
Yeah.
And number two, data collection. I think this is so important, with Isar did at one time, tried to do it, and then they left it. They called it NARI, National
Yeah.
Data Collection. I think
Registry.
something like that can be done till ICMR really has a proper hold on all the centers. You see, how do we tell that what are our pregnancy rates? I may be truthful and I would give a pregnancy rate of whatever my center has. Someone who has a, I'll tell you, most of the centers don't have a pregnancy rate. Uh, I'm not talking about clinical, a positive beta HCG rate of more than 25% in today's world also, and with 2 or 3 embryos being transferred. I'm talking of more than 50% centers are like that. 50% are definitely good centers, and they are giving better pregnancy rates and doing one or very few centers are doing single embryo transfer. We resorted to that since 2015. Thanks to
Okay.
our embryologist who gave us this confidence. Otherwise, we would
Yes.
have had to, would not have been able to do it. But I want someone to audit and see.
Yeah.
I don't know how you can manage it. You are one of the chairpersons of a very important committee. Maybe you can influence the person who's on the infertility chair. And auditing of results is very important rather than just whatever random someone puts on their website or puts wherever.
Yeah, we need a very structured regulator
Yeah.
like HFEA, something like
Yeah,
that.
like HFEA,
Yeah.
correct. Yeah.
So after decades of helping thousands to achieve parenthood, and what is the message that you'd like to leave with the Foxy members, young people who are listening to our podcast today, and anything else that you want to say, please go ahead.
Yeah, I think it is better to take a staircase when you're going uphill and not the elevator. You learn a lot on the stairs. And I think my life has been a staircase only. At this age and stage, you've asked me to have a podcast. People have it at much younger ages also, you know. So I think working hard, reading and practicing what you read. Say you read that progesterone is required for luteal support, but then when you give your luteal support, it has 20 drugs or 10 drugs in it. You're not practicing what you read. A natural cycle embryo transfer is so much better. Yet we only resort to HRT. Why? Because it's easier, it's convenient. Think of the pills the patient is ingesting of chemically driven estradiol. So my message to all my youngsters would be, please read well, learn your skills, but never leave ethical practice. That will take you a very long way. That was the only staircase which I took that I could reach where I am today, by learning, teaching, and ethical practice.
I'm so humbled today, madam, to connect with you. I mean, obviously for the audience, but for myself personally, I feel that people like you who have decades of experience, we want to listen to you very carefully, and I'm really very honored that you agreed to take time and share your thoughts with all of us. And thank you very much for your time, madam.
Thank
Thank you.
you, Anu, for
Thank
having
you.
such a nice questionnaire for me to answer. Thank you.
I think this was more technical than any other podcast because I can't have you and not ask those questions. So thank you, madam.
You're welcome.